Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Good morning, good afternoon. I'm Lon Schneider, and I wanted to welcome you to this Medscape Educational Conference on biomarkers, genetics, anti-amyloid therapies for early-stage Alzheimer's disease. Together, Doug Glasgow and I will take you through several aspects um, of biomarker considerations in the treatment or in considering treatment with amyloid targeting antibodies. First, we'll discuss biomarkers in Alzheimer's disease in general, and then the role for and measuring biomarker in early stage Alzheimer's disease. And thirdly, interactions of APOE genotyping and considerations for amyloid targeting therapies. As an introduction, we first wanted to sort of set the stage for what we're discussing. So, first, clinical syndromes. We refer to the clinical syndromes in practice in terms of first people being cognitively unimpaired or having mild cognitive impairment or reaching a dementia stage, which may be mild, moderate, or severe, with impairments of activities of daily living. Mild cognitive impairment and dementia as syndromes do not imply an etiology. And for that, you'll see, and for this discussion, we'll be talking about biomarkers as helping to provide the etiology. A word on Alzheimer's disease pathology. Alzheimer's disease itself is defined and has been defined for decades as amyloid plaques and neurofibrillary tangles representing tau proteins along with atrophy. And this is the light microscopic and ultimately clinical definition of Alzheimer's disease. We see a pattern, a pathologic pattern in which plaques and amyloid fibrils may activate microglia, may set off an inflammatory process, and then neuronal death and the manifestation of tau proteins. And we wanted to set this simple model for Alzheimer's pathology to set the stage for our brief discussion on biomarkers. So, within that context, we can overall uh, describe a person as going through a sequence of changes that are reflected in biomarkers. That A beta 42 peptide might be the earliest biomarker seen in CSF and plasma, followed by the recognition of plaques on PET scans, amyloid plaques on PET scans. And soon after, or almost at the same time, the ability in CSF to detect phospho-tau, total tau, and amyloid fibrils. This progressing to seeing in the CSF other proteins indicating neurodegeneration, and somewhat later, tau fibrils and neurofibrillary tangles that can be visualized with PET scanning. Sometime after that, in our model of Alzheimer's disease, uh, MRI measures of atrophy or recognition of atrophy, especially a cortical temporal atrophy can be recognized. And that is essentially the sequence of biomarker expression in the course and development of the clinical syndromes and cognitive impairment. So it's because of this that we can also speak in addition to clinical syndromology, we can speak towards Alzheimer's disease as a biological entity. It's defined as plaques and tangles under microscopy. And we can also take this a step further and describe the presence of abnormal amyloid biomarkers, abnormal tau biomarkers, and biomarkers of neurodegeneration. And in that way, classify people in terms of the absence of Alzheimer related pathology by not observing amyloid, tau, or neurodegenerative biomarkers, or we can classify on the basis of partial expression of seeing a positive amyloid biomarker, but not a positive tau or positive neurodegenerative biomarker. So we can talk about that positive amyloid biomarker as Alzheimer's disease pathologic change. Similarly, we can talk about the presence of an amyloid positive biomarker and a tau uh, positive biomarker, tangles on PET or phosphatau 217 in plasma, for example, as Alzheimer's disease, even though we might not address symptoms at the moment in this classification. But the classification or the obtaining of biomarkers also leads to the potential observations of seeing abnormal tau without a positive amyloid biomarker, or seeing neurodegenerative biomarkers or atrophy without a tau biomarker or positive amyloid biomarker, which would indicate non Alzheimer's pathologic change. We also speak in a basic Alzheimer biomarker language about the core biomarkers, core one here, or sometimes called canonical biomarkers of A beta 42, amyloid PET, and then phosphatau 217, phosphatau 181 in CSF, and other phosphorylated species such as phosphatau 231 as being particularly predictive of Alzheimer's disease pathology. In addition to that, we discuss and speak about other biomarkers that may be supportive of neurodegeneration, such as neurofibril light protein and GFAP, a protein indicating astrocytic activation and possibly inflammation. And we also, in our expanding world of biomarkers, will consider vascular injury and alpha synuclein, which is now more associated with uh, Parkinson disease or Lewy body dementia. So there's an evolution of biomarkers that we can use clinically, or at least can consider within the context of treating patients with amyloid targeting therapies. There are two amyloid targeting therapies in use, as you know, lecanemab and donanemab. It's approved on the basis of showing drug placebo differences on clinical outcomes. It is also recognized that the reduction of amyloid plaques could be associated with future benefit. At least that's an FDA's view. And also commonly, the amyloid targeting antibodies are associated with unique safety concerns, including infusion reactions, especially for lecanemab, and then high incidences of ARIA, and essentially edema and hemorrhage in patients who receive them. So then the eligibility for amyloid targeting uh, therapies rest not only on recognizing a clinical syndrome of mild cognitive impairment or mild dementia, but also on the use of biomarkers to predict or suggest the presence of amyloid pathology. P-tau uh, uh, 217 in plasma is particularly predictive of amyloid plaques, and amyloid PET recognizes amyloid plaques. So, Doug now will discuss measuring biomarkers in early stage Alzheimer's disease.
Great. Thanks, Lon, for giving us the background. So, in clinical practice, we need to think about how to use Alzheimer biomarkers. The first question is, why should we measure them at all? So, one obvious reason is to obtain as good or as clear or as definitive a diagnosis of Alzheimer's as possible. In other words, to be able to determine that there are Alzheimer pathological changes in the brain. This allows for early intervention if we're able to make the diagnosis early, and it allows the patient and family to try to make a number of changes to be able to preserve independence for as long as possible. And it also allows a patient and family to plan for the future if we're more confident about ruling in or ruling out Alzheimer's disease. Furthermore, these biomarkers can be used to determine if a patient is eligible for clinical trials and also for treatment with one or other of the two anti-amyloid therapeutic antibodies that Dr. Schneider mentioned. So, who should we offer biomarker testing to? One situation is people where we strongly suspect Alzheimer's disease. We see them at a relatively mild stage, and we wish to determine eligibility for anti-amyloid antibody therapeutic treatment. There are some other settings, for example, people with an unusual or atypical presentation of dementia that sometimes could be due to Alzheimer's or due to some other process, people with early onset dementia before the age of 65, people with an uncertain dementia where maybe there are a number of medical factors, depression and so forth that could be contributing, and we're trying to sort out whether a neurodegenerative process could be present or might not. And so, as Lon mentioned, there are three major approaches to measuring Alzheimer biomarkers. The first is to do an amyloid PET scan. Another option is to obtain a lumbar puncture for CSF testing. And the most recent set of options are to obtain a blood test for plasma biomarker testing. And there are a number of different analytes that can be measured in plasma, most recently measuring both p-tau217 and A-beta 42 and combining them into a ratio was approved by the FDA in May of this year. A number of laboratories are offering the ability to measure p-tau217 on its own, and so there are a number of different options out there. So let's talk about amyloid PET. The diagram illustrates, in a colorized version, what a positive amyloid PET scan might look like, with tracer showing uptake in a number of different cortical areas. There are several FDA-approved tracers that are available for amyloid PET, and there's one that's been FDA-approved for tau PET. The amyloid tracers have more than 90% accuracy to detect moderate to severe amyloid plaque density, and these have been studied in patients who had an amyloid PET and then were followed up and later had an autopsy where brain examination was done. Generally, a reading of an amyloid PET scan is done by a nuclear medicine specialist, and they will report the scan as being positive or negative. It also is possible to obtain a measure of amyloid burden, and a quantitative result of amyloid burden is often used in clinical research and is sometimes offered in practice. There are some advantages of amyloid PET. It's extremely accurate, and there are very few reasons not to be able to do an amyloid PET scan, whereas there sometimes are reasons not to be able to do a lumbar puncture. Some of the disadvantages are it is quite expensive, availability may be limited, and its specificity declines with older age. In other words, people in their 80s and 90s may have background amyloid positivity and symptoms that might be caused by something else. Some appropriate clinical scenarios for amyloid and tau PET have been developed by expert panels. For amyloid PET, there are a number of different potential indications, similar to some of the things I talked about earlier, MCI or dementia where Alzheimer's is suspected. Maybe there may be atypical features. Maybe a patient had a lumbar puncture and the CSF biomarker testing is equivocal or inconclusive. And maybe one wants to learn more in someone who has mild symptoms about prognosis. And then most recently, amyloid PET is being used to determine eligibility for anti-amyloid treatment and to be able to monitor responses on an anti-amyloid a therapeutic antibody. One of the few reasons why one might not be able to do an amyloid PET would be if a patient has had too much radiation exposure in the particular year. And amyloid PET is generally safe and the amount of exposure is low, but some patients might have had a host of other radiological studies for one reason or another. There is one other contraindication for an amyloid PET scan, but it's unlikely to happen the first time one scans someone, and that is that some people could potentially be allergic to the tracer that's being used. But there's no way to predict that in advance because they wouldn't have been exposed to the tracer before having the amyloid PETs. And in my experience, it's been extraordinarily rare to see that sort of allergy. And a similar discussion applies to tau PET. It can be used for diagnosis, especially in early stages, or prognosis. At the moment, it's not being used to determine eligibility for anti-amyloid therapeutic treatment. So let's talk about CSF biomarker testing. CSF requires obtaining a lumbar puncture. A number of studies have calibrated CSF against amyloid PET, and it is at least 90% accurate. The advantages are that one can measure a host of different proteins in the same sample. It's less expensive than amyloid PET. And at present, there are 3 different CSF assays for Alzheimer's that are FDA approved. Some of the disadvantages are that it's difficult for a clinician to get adequate reimbursement for doing the lumbar puncture. There's a perception that lumbar punctures are dangerous and invasive. There are some contraindications, for example, people taking blood thinners or people who have had lower back surgery or have lower back infections or sepsis. And there are potential adverse effects, the most notable of which is a post-lumbar puncture headache. And there may or may not be available clinicians with expertise to be able to perform lumbar punctures in an easy way. In terms of how one interprets a CSF readout, it depends on which test is used. One option is to measure the ratio of A beta 42 over 40, and this ratio is low in people who have AD because as A beta 42 is deposited within plaques, less of it gets into the CSF. Another way of thinking about this is to measure one or other of the versions of tau, p-tau 181 or total tau, and then combine that with A beta 42. In this case, the A beta 42 levels are low, the p-tau or total tau levels are somewhat high, and so ratios are higher in people who have Alzheimer's disease. A major breakthrough in the last few years has been the ability to detect a number of these proteins that are made in the brain by measuring them in the blood. And so the same cast of characters can be measured, A beta 42, 40 or ratios, p-tau 181, and a new version of p-tau called p-tau 217, which turns out to be the most sensitive and accurate. And a test based on combining p-tau 217 and A beta 42 as I mentioned, was approved by the FDA. So the strengths of blood-based biomarker testing is that it's very easy to get a blood test. It's easily accepted by patients. Um, there are some questions around the blood-based biomarkers. The accuracy may vary, and if you're going to order it, look at the lab who's going to be doing the test to see exactly how they have defined and calibrated their cutoff points. It does not provide information on the regional distribution of pathology, and at present, blood-based biomarkers are unlikely to be reimbursed by insurance. How to interpret blood-based biomarker results? We generally interpret them as ruling in or ruling out Alzheimer's pathology. There is some nuance to this. So for CSF and amyloid PET, there's usually a binary report. People are either positive or negative. It turns out that for blood-based biomarkers, in order to obtain the highest sensitivity and specificity, a high cutoff and a low cutoff are often used. And under this scheme, up to about 20% of people might have intermediate results on a blood-based biomarker test. If that is the case, for intermediate results, a confirmatory test with CSF or amyloid PET, or even repeating the blood test at a later date, would be recommended. There's a question about amyloid PET is very expensive, and if it isn't widely available, for example, in many European countries, does that preclude people from prescribing amyloid targeting therapy? The answer is no. A lot will depend on what local country regulations are. In the US, in terms of getting anti-amyloid therapy reimbursed through Medicare or CMS, a confirmatory test is necessary, and either amyloid PET or CSF biomarkers are required at present. Blood-based biomarkers have not yet been approved or recommended by CMS in order to be able to start anti-amyloid therapy, but that situation might change. So I'm going to hand back to Lon, who will talk about another aspect of testing, APOE genotyping.
Okay, we wanted to discuss APOE because of its importance in Alzheimer's disease and its importance in treating and considering treating with amyloid targeting antibodies. APOE gene codes for apolipoprotein E, and there are three alleles and three types of protein: ApoE3, ApoE4, and ApoE2. ApoE3 is the most common at a prevalence of about roughly 75% in the population, and ApoE4 at a gene prevalence of about 25%, roughly. There is a certain risk for ApoE4 carriers for developing Alzheimer's disease earlier in life and at a greater rate. The ApoE4 status, however, does matter with respect to amyloid targeting antibodies. For example, the overall rate of ARIA with edema, ARIA E, with lecanemab is 12%, with donanemab is 24%. But you can see that if you are an ApoE4 homozygote, your rate increases 2 to 3 times to 32% to 40% or so in terms of incidence of ARIA with edema when treated with these drugs. There's an increased risk if you're an APOE4 carrier in developing microhemorrhages. This is a feature and a consideration in treating. Of note, just this month, the companies in FDA changed their warning, their black box class warning for the two anti-amyloid antibodies to indicate that under some circumstances, the development of ARIA could be a serious and life-threatening event and can be fatal. But this underlies the need to ApoE genotype people who you're considering treating with an amyloid targeting antibody. The prescribing information goes on to actually suggest, and clinically, we suggest that one first ask a participant, a patient, about whether you can genotype, and then speak in advance about what an ApoE4 versus an ApoE3 genotype may mean for the individual patient, and for those who are APOE4 carriers, the increased risk. An APOE4 genotype or a APOE4 proteotype can be obtained almost anywhere. Discussing the potential implications with somebody who may want to receive amyloid targeting therapy is essential in consideration of treating. Our take home points are these: biomarker testing can predict the presence of amyloid plaques and Alzheimer pathology, uh, that the incidence of ARIA is related to APOE4 genotyping and especially homozygosity. And one needs to consider APOE genotyping before starting amyloid targeting antibodies. So, with that, thank you for listening to us and hope this was helpful.